A little bit about Results and the work that we do on tuberculosis. Results is we are a grassroots advocacy organisation working to empower local citizens in the UK as well as to inform decision makers on the worst aspects of poverty, challenges as well as solutions. Part of the health advocacy that we do is around tuberculosis and child survival. And around that we have a particular interest in TB HIV co-infection, which is a key organisational priority for us. I wanted to just quickly go over some key TB facts for those who may not be very aware of TB HIV co-infection. In 2013, TB will kill 1.4 million people around the world. It is the leading cause of death amongst people living with HIV, and latest statistics show that without treatment, 90% of HIV positive people will die from tuberculosis within months. Scarily, because tuberculosis drugs currently available are so decrepit and old, they are currently over 50 years old, there are increasing rates of drug resistance. And so we now have drug resistance against first-line medicines, which is known as MDR-TB, and then we also have drug resistance to both first and second line drugs, which is known as XDR-TB. While MDR-TB increases the fatality rate amongst people living with HIV, with XDR-TB, which is now present in almost 53 countries around the world, it has a 100% fatality rate amongst people with HIV. TB is a disease of poverty and is the highest burden countries are concentrated. 13 out of 22 of the high burden countries are based in Africa. And as I mentioned, most of the TB drugs are 50 years old. The most commonly used diagnostic tools used are 120 years old. And the vaccines we have in existence, well, just one vaccine that we have in existence for TB is over 90 years old. It is estimated that at least half of all people with TB are still not properly diagnosed, and for the people who have MDR-TB, it's estimated that only 3% of them are currently being treated. So to bear in mind some of the costs, it normally costs around $10 US to provide someone with treatment for regular tuberculosis that's drug sensitive, and that course of treatment will usually be 6 to 8 months. For someone who has multiple drug resistance, that drug treatment regimen increases hugely by almost an order of 100 times in terms of cost, and in terms of duration of treatment, it goes from 6 to 8 months to 18 to 24 months. People with HIV are increasingly much more susceptible to contracting tuberculosis because of their reduced immune systems. And unfortunately, the combination therapies of taking ARVs and tuberculosis treatments do not fit well together at all. And often they cause really severe side effects together. So you have the side effects that come with ARVs and you have the side effects that come with TB medicines. And often there are a range of MDR treatments that HIV positive people cannot have, for the sheer fact that the side effects alone are far too dangerous for them. And then you have those side effects coming together. So what you have people who understand and recognize that their ARVs have to be taken every day in order to keep them alive. And unfortunately, because the side effects of the TB drugs is too much for them to tolerate, they will choose not to continue their TB medicines, which ultimately means they then develop drug resistance. And then comes the associated problems of having to get more drugs and try and deal with that drug resistance. So at this point, I would like to share a video, a quick video from a former TB patient called Oksana, who is from Moldova.
My name is Oksana. I am from Belts. Belts is situated in the Republic of Moldova. I led a normal life. I was working as a program assistant in Chisinau. And I was just a woman like many in my country. The symptoms of a TB are coughing, losing weight, temperature, fatigue, constant fatigue. I've been diagnosed with TB in 2007. I followed 1 year treatment, and after all it turned out that the pills are not doing their job. I was diagnosed, it was July 3rd, I remember this day, diagnosed with MDR-TB. MDR-TB is a kind of different tuberculosis. It's much more difficult to support. And after being diagnosed with MDR-TB, I had to stay 6 months in hospital. It takes about 2 years, at least 2 years of treatment with about 20 pills a day. I don't think that if they are owned for Global Fund, my government of my country could afford the costs of the MDR treatment. I think MDR people deserve a second chance. They deserve to live, and they deserve to get cured and to be reintegrated in society.
So, as Aparna mentioned, when she was diagnosed with MDR-TB, she had to take 2 years' worth of treatment. And again, the drugs she's taking are at least over 30, 40 years old for MDR-TB. So what do we have currently available in terms of fighting tuberculosis? So, as I mentioned, most of the tools, they're old, they're slow, and sometimes they're ineffective. We have significant challenges in using the current treatment in children. The pills are quite large, they're difficult for children to swallow, and we have no pediatric formulations. So often there is a WHO recommendation, but it's very difficult to essentially crush up different combination therapies and then to try and make them palatable for small children to be able to take and not throw them up or refuse to take them. Then there is the issue that there are certain tuberculosis drugs that HIV positive people can't take, and then there are additional problems with side effects and how to distribute this treatment to drug users and other vulnerable groups. As I mentioned, drug-resistant tuberculosis is on the rise globally, and in many high-burden countries, their surveillance is so poor that they're not able to detect the number of true cases of drug resistance they have, and therefore they're not able to procure the right amounts of MDR-TB drugs that they actually need in the country, which in turn then gives rise to stockouts and people developing drug resistance. As I mentioned, we do have a TB vaccine, which all of you should be familiar with. It's the BCG, and as I mentioned, it's over 90 years old. However, most people assume that when we have the BCG as infants, it provides us with lifelong immunity, and actually, in fact, that's not the case at all. The BCG really only protects children and up to the age of adolescence against the most severe forms of tuberculosis, so TB of the brain, for instance. But what it doesn't offer is protection against the most infectious and most common form of TB, which is of the lungs. It's also a good time to note that you can actually get tuberculosis in any part of your body except your hair and your nails. And it's actually more common for people with HIV to have TB elsewhere. That's non-infectious, in their kidneys, in their wombs, in their knees, anywhere. The problem with this then becomes, in terms of diagnosing tuberculosis, the most common form of diagnosis we have is taking a sputum sample, so coughing up from right at the back of your lungs to produce a sample that can then undergo smear microscopy. But because the symptoms are generated differently in people with HIV positive, their tuberculosis bacterial load isn't necessarily manifested in their lungs, so even if they have active TB disease, to produce a sputum sample doesn't necessarily always give a clear definition or precise result. One of the other things to note about the BCG vaccine is that because it is a live attenuated vaccine, that means it's the live form of the tuberculosis bacteria, but it's been severely weakened, it can't be administered to HIV positive babies. And so it can't offer them any protection even from TB meningitis. However, it's important to note that tuberculosis is preventable, it's treatable, and it's curable. There is no reason why anybody should be dying from tuberculosis. And so there are key things that we need in order to prevent these deaths. One is a cheap and simple point of care test that can rapidly deliver results, enabling people to go in for a test and pick up treatment on the same day. We also need drugs that treat tuberculosis quickly and with far less severe side effects. And also we need an effective vaccine that can be used across the age groups. So some key examples of innovation in TB HIV is we've come a long way in the space of 10 years in terms of tuberculosis, and a lot of that has come through R&D investment, through product development partnerships. These are particular models where they knit partners from across academia, industry, private and public sectors to collaborate on investments and research so that they can simultaneously work on specific products, so whether it's a vaccine or a drug or a diagnostic, and really sort of fund an entire chain of development to get a product to market. Some that I would like to highlight are diagnostics. So 10 years ago, we didn't have any new diagnostics apart from this basic microscopy. We didn't have any research or tools in the pipeline. And in 2010, to kind of show how much progress we've made, FIND, which is the Foundation of Innovative New Diagnostics, launched a new machine called the Gene Expert. And this machine has been able to revolutionize the way in which we are able to diagnose tuberculosis and drug resistance. It's essentially, you take a sputum sample, put it in a cartridge, you run it in this machine, which you can see in the picture, and it takes 2 hours to come up with a result. There have been recent studies just launched earlier this year which have shown that Gene Expert is a significant improvement in terms of being able to positively diagnose tuberculosis and drug resistance. And because of its sensitivity, it also means it can give a definitive result much quicker and clearer for people with HIV, where sputum microscopy just wouldn't work. So, another thing I'd like to highlight is earlier this year, a new TB drug came online called bedaquiline. Yes, that's it. And this is, which is newly approved by the USA FDA. People. It's exciting because it's the first new drug we've had since 1970. And then in terms of vaccines, compared to 10 years ago when there was nothing in the pipeline, we now have the results of a new vaccine, which has been the first one to enter into large-scale clinical trials in over 50 years. The product is called MVA85. It's been tested in South Africa. It's just launched its results for infants, where it's been shown to be safe, but it hasn't shown a significant increase in being able to boost their immunity. A second part of that trial, which is currently undergoing, with results due in March of this year, is the results from a cohort of HIV positive adults. And now they're testing to see if this vaccine can offer them increased protection against tuberculosis. And so it's a really exciting opportunity for us to kind of see how all these investments in R&D, particularly through PDPs in the case of tuberculosis, are really helping to generate some exciting new tools that can be used across different populations. And so really what we're hoping to do is through further investment, we can really bring that TB drug treatment down to just a matter of weeks rather than years.